You're listening to Health Innovators, a podcast and video show about the leaders, influencers, and early adopters who are shaping the future of healthcare. I'm your host, Dr. Roxy Mooney. Welcome back to the show, Health Innovators. On today's episode, I am sitting down with Rebecca Love, who is the Chief Clinical Officer at IntelliCare. Welcome to the show, Rebecca.
Thank you so much for having me, Roxy. It's such a pleasure to be here.
I am very anxious to have this conversation. So you were just on the Modern's top 100 most influential people in healthcare. Congratulations.
Roxy, thank you so much. I really was blown away when that actually happened. Quite a surprise. I don't think any of us ever expect to show up on a list like that. And then also being a nurse and who was on that list just blew my mind. So thank you.
Exactly. You're in great company, right?
Let's keep going.
So before we start off the conversation, just tell our audience a little bit about you, your background, and what you've been up to these days.
So, Roxy, by training, I'm a nurse, and I spent a large part of my career as a nurse practitioner. I eventually started my own company for a job board when I was teaching in a community college, spun that out after going to a hackathon to build the first nurse innovation program in the country at Northeastern University. We took that, put it into a national, international nonprofit called Sanciel, which really drives nurses to be at the forefront of driving healthcare innovation and entrepreneurship, because we fundamentally believe that we should be looking at nurses as a source and a resource, all of the trust that we've earned through the Gallup poll to transform healthcare, because nurses are at the closest to the patients that we have. But in my day job, in addition to that, I serve as the Chief Clinical Officer of IntelliCare, which is one of the largest workforce management solutions for nurses and CNAs across long-term care, with the basic premise that if you gave nurses technology so that they could have more of a work-life balance, pick up shifts when and where they want to work, the reality is we could optimize and drive efficiency of that workforce to work greater, but have greater ability to enjoy that life that they sometimes feel is lacking in our traditional models around nursing staffing.
Incredible. That is such an incredible mission and purpose on so many different fronts. So, I want to just kind of pose this pretty provocative question for you. On the show, I have a lot of guests that come on and they're talking about their commercialization journey or how to commercialize something successfully. So I would pose this question to you. Can we truly transform healthcare through all of these innovative solutions without nurses?
I don't think so. And here's the reason why is nurses represent about 5 million of the workforce in the United States. That not only makes them the largest workforce in the United States, that makes them the largest workforce in all of healthcare. They are the front line. And I tell a lot of individuals this, but I don't think people understand that the reason that patients are in hospitals or nursing homes today is because they need 24/7 monitoring by a nurse. Otherwise, their life is at risk. And what that means, everything else could be done outpatient. Physical therapy, doctor's appointments, surgery, occupational therapy, respiratory therapy, all of that could be done external. Being in the hospital, being in the acute care environment, even in the subacute or post-acute settings, means it is the nurse who sits between the patient and the provider, and all of the orders, the technologies, the medications, the reporting, all of that comes down to the nurse to initiate that. So when you are a healthcare company and you're trying to sell a product into healthcare, the end user of that product is more than likely a nurse. And if you have not engaged with the nurse to develop that product, to give you insights, to be at your executive level, the likelihood is what you have done is you have created a solution for something that either one, does not address a real problem, or two, it creates more work for the nurses on the front line, driving to the burnout that we're seeing today, which is leading 1 in 3 bedside nurses to leave the bedside by the end of this year, sparking perhaps the largest nursing crisis that we've seen in our time on this earth.
So fundamentally, you've talked about a couple of things that really resonate with me. For one is that the number one reason why innovators fail to commercialize their innovations is because there's no market need for it. And so we are certainly missing a number of different voices, the patient voice and certainly the nurse voice in that process of product development and product management to be able to bridge the gap to make sure that we are meeting a need. And then on the other end of that, once we actually build something and we sell it, the adoption of that, it's just so fascinating to me that we kind of can view that we're successfully commercializing something because we're driving sales, but then we have very, very low adoption numbers. And I think a big part of that is really what you just described, is that nurses play a critical part in implementing and leveraging those innovations. And if we don't involve them in the process, they can easily throw their hands up and say, I'm not using it. And then
exactly. What do you do? And again, you're back to the drawing board, right? And it's so interesting to me because I'm sure you would like me talk to all of these venture houses and all of these VCs and other individuals who are investing, and they have a very high level understanding of the problems, but have a great belief in their solutions as a way of understanding the intricacies of what's going on within the dynamic healthcare environments. And what we find is a breakdown almost immediately of those who walk into scenarios where they're reading it in the news, like we need to solve congestive heart failure and we need to solve diabetes, or we need to solve readmission rates along these lines, and come at it with very much a prognosis of a situation that is an easily solvable situation with technology or other kind of programming, without really well understanding the 365 view of what happens in those moments or in between. And I know that you and I were just at a conference, and what I was blown away with was the significant number of incredible population health programs that were out there. But what really triggered for me, my thought is we're spending billions of dollars on technology, for example, who can manage congestive heart failure, but only manage congestive heart failure of patients who are compliant, right? None of these technologies can manage congestive heart failure in a patient who has diabetes and acute pneumonia. That takes a nurse to do all these things. And I'm looking at all of these dollars being spent in technology, which is absolutely brilliant. But then I'm looking at a waning and a collapsing nursing workforce. And I wonder, how long have we been investing in technologies where if we had been investing in the nursing workforce, we could actually have a population who has better patient outcomes, is saving lives, because we produced massive amounts of qualified, highly skilled nursing workforce that then could work with these technologies to enable better outcomes across the sphere. And right now there's a severe divide. And what we're finding is that this misalignment and direction of focus of investment so much into a world of technology perhaps is actually causing an implosion of that workforce who was designed to give that care.
Preach, Rebecca, preach. What are some of the other, so we were just at the health conference, right? So what were some of the other observations that you made there? Either, things that are really fantastic and, excited to really be able to see and how we're moving the industry along, and maybe some, kind of like what you just identified, some additional gaps that we're still needing to fill as it relates to nursing.
Well, it was very exciting because for the first time ever at Health, there was actually a panel of us that were nurses that were put on the stage at HLTH, which you would think that probably seems like something that would have always been happening, but largely nurses had been left out of those conversations. And I think that showing that progress and also showing the attendance and the follow-up that happened from it, it showed the value of nurses being intricately involved in this conference to define in which their scope of practice, what is working, what's happening. And I was joined really by Bonnie Clipper, and also Hiyam Nadel, who Hiyam Nadel is the first nurse ever appointed as the director for the Center of Innovations at Mass General Hospital, which as her determination as a nurse determines which products are brought in to the Mass General to be used by nurses. So we're seeing a cultural shift around this environment and also having nurses participate. The other thing that I would say at Health is there are some outstanding programs that are being developed that actually can enable less work for nurses and actually enhance their delivery of practice. So things that you can absolutely, the use of, I think we know this, remote patient monitoring, systems that create less work for nurses, but can actually drive extra eyeballs onto complex patients to monitor those patients are absolutely brilliant. And I think the idea of how do we better enable technology so that we're not adding one more thing onto a nurse. And Hiyam pulled this brilliant sheet out and she said, actually, I'll show you. She pulled out like one page like this. And she said, this used to be the size of what it looked like for a nurse to do a one pager per patient that would come into the hospital. She said in the last 10 years, she rolled out a 6-foot page and said, now these are all the things a nurse has to do to care for that exact same patient just 10 years later. So all of these technologies who say, you know what, the nurse is going to do it. We're going to have them do one more click, one more intervention. What we've seen happen is that absolute scrolling of managed tasks that are just something that is really, really going to be something that we need to bring attention to within this next era of tech development.
So what do you say to all of the inventors and innovators that are in the audience that are at various, stages in this commercial process, maybe pre-revenue, early revenue, or maybe they've even successfully commercialized their innovations? What do you say to them about how to solve for the issues that you're discussing?
You just need to bring nurses into the conversation. They are such brilliant innovators. And the one thing that you're going to know about nurses is nurses don't innovate to make money, which is just because it's just not something that we inherently do. We innovate to save lives or alleviate suffering in the populations that we see. So when you talk to a nurse, you're getting this really critical understanding of how can you make the greatest impact to saving lives. They understand the patient from levels that, literally a nurse spends 24 hours a day with a patient, where a doctor may spend less than 15 minutes on average a day with that exact same patient. So the intricacies of defining a problem, especially in healthcare, which is nothing is a straight line, right? Like the truth is there's very much a bell curve here that you have outliers, but nobody follows the same path. The reality is when you talk to those nurses and those years of experience of managing patients in both complex environments and post-acute environments, you get this view and understanding of a problem solution fit that nobody else is going to give you. But more importantly, they're going to tell you in manners that their expertise has been trained to always drive to the most efficient outcomes. And that, I think, is something that any true innovator is truly interested in. They want to make sure that their device delivers on the actual problem and really does impact the life in a positive way in which they're treating.
So what a great description of how to solve for the challenge that you're talking about, especially the role that nursing can play within an innovative company or business. Let's also talk about what you see happening for the nurses that are at the intersection of all of these challenges, who are finding their entrepreneurial spirit themselves and deciding to solve for their problems by starting their own companies. What's happening there?
Oh my gosh, I think there is an awakening in the nursing workforce who recognizes that the problems that they are trying to solve mean not only could they solve them for one patient, but it means they could scale them and solve them for many. And I think the truth is, though, that when nurses innovate, as I said, it's because they've experienced a situation that was so devastating to them or so highly inefficient that they recognized that it was jeopardizing their ability to deliver care safely, or they saw that the way that they could develop a device would actually prevent harm to a patient in areas that hadn't been addressed. So there's a woman by the name of Roxanne McMurray, and she is a clinical nurse anesthetist, and she came up with an oral airway from her years of time of having to deep intubate individuals. And all she came up with, it was a whole new oral palate extender that allowed for deeper use of oxygen. She was absolutely brilliant and brought this idea to marketplace. And it has dramatically decreased the risk of needs for deep max, which is a tremendous impact to the business. And then I see other nurses who are recognizing gaps in care. And what they're recognizing is that in this world of complexities of payers and continuing in case management that largely falls in the gaps, what they are really good at is getting and helping patients care and delivery of services at home. So you see a group like Navi Nurse, which were two Mayo nurses left this and started a concierge practice of delivering basically hospital level care within the home. And they have been so successful at doing this. And they did it because they recognized too many of their patients were languishing in hospital beds when they only wanted to be at home. So we're seeing nurses come out to solve the problems that I think we as an industry or as a healthcare system have always wanted to address. But they will also take the problems that do not have the reimbursement models in place that drive the dollars. So you see nurse practitioners dealing with the homeless and setting up clinics in the largest community, housing complexes in the country, in Washington, D.C. Nurse practitioners and nurses address the areas of the population where money was not their priority, but alleviating suffering and driving better outcomes for their patients are absolutely critical to them. And I think that is, you cannot find truer innovators and truer
Social
human beings.
entrepreneurship.
Yes, exactly.
Yeah.
Except for nurses, they do it, and they do it for them. They do it for their. They do it for just such different reasons than I think we see in the industry. And it's just, if you want to feel inspired, learn more about those nurse innovators and their stories about why they've developed what they have. None of them came out of a venture house, and none of them came out of a ton of money. Most of them cashed out their retirements, like I did on my first company, and we did it because we wanted to make the world better for those who are around us.
That's exciting. Hey, it's Dr. Roxy here with a quick break from the conversation. Are you trying to figure out what moves you need to make to survive and thrive in the new COVID economy? I want every health innovator to find their most viable and profitable pivot strategy, which is why I created the COVID Proof Your Business Pivot Kit. The Pivot Kit is a step-by-step framework that helps you find your best pivot strategy. It walks you through 6 categories you need to examine for a 360-degree view of your business. I call them the 6 critical pivot lenses. As you make your way through this comprehensive kit, you'll be armed with the tools, tips, and strategies you need to make sure you can pivot with speed without missing out on critical details and opportunities. Learn more at legacy-dna.com/kit. So we're starting to see some progress in solving these problems, giving a voice to nurses, both within the Innovators company and then as well as them moving to entrepreneurship themselves. So what are some of the things that we still need to solve for? Because I know that you're working on some pretty exciting stuff.
So the biggest one is the current workforce challenges. So McKinsey did a study, 1 in 3 bedside nurses are leaving the profession by the end of this year. And what that means is we were predicting a 1 million nursing shortage to hit by the end of 2030. We think that is going to accelerate to hit by the end of this year. And why that's a problem, and actually I was sitting on a board in a panel with Accenture a couple of weeks ago, and one of the hospital systems says they're actually predicting a 2 million gap by the end of 2025. And why this is a problem is because if there is not nurses, there is not healthcare today. Like, you can have all of the tech in the world, and you can have brilliant patient engagement platforms. But if you have a patient laying in a bed who cannot lift their bed because they are racked with an infection, they can barely breathe, they are in total sweats, they have wounds breaking down their body, they cannot eat. That is the nurse who's going to hang those $1 million in medications, manage the millions of dollars in technologies and medications that you're going to be delivering to that patient, clearing their lungs with the suctions that go on, emptying their urinals to make sure, and monitoring for signs of infection. And the truth is, if they're not there, we don't have a healthcare workforce. And so the biggest challenges that I see currently are nurses' reimbursement model. And this dates back actually to the 1930s, when the healthcare systems started to look at ways to create reimbursement. And they looked to hotels and they said, oh, you have maids, they're rolled into room rates. Let's take nurses and roll them into room rates. And what that did is it placed nurses invisible. They stopped charging for nursing services on their bills. They saw nurses as economic competition. I talk about this in another time, but we should talk about this because the history of what happened there is, maybe we should just say, in the early 1900s, nurses fought hard for women's right to vote in this country. 1920s, the 19th Amendment passed, women have the right to vote. Nursing in the 1920s becomes the most economic vehicle for women to obtain economic freedom in this country. The first time was a mass revolution. Nurses at that time were all independent entrepreneurs. They ran their own practices. Hospitals were places where only the most destitute thought care, because they were deplorable. The conditions were awful. Right. So these are things. And so what they did is families would hire private duty nurses to come into the hospital. They'd be issued 2 bills. Hospitals started to see that care started to get better with nurses, and they started to employ them. And that in the 1930s is when those models to develop it. They started to recognize nurses for economic competition. So they rolled them into the room rates to hide their value. And in the last 100 years, nurses have always remained on the cost side of the ledger. And why this is a problem is there's reimbursements for physicians, occupational therapists, respiratory therapists, physical therapists, nurse practitioners, dietary services. Every other professional in healthcare has a reimbursement line. Only nurses has been mirrored in the past. And as long as they remain a cost center to healthcare systems, they will not be invested in. And with the cost of labor and everything that's going up, hospitals can't afford the workforce in the traditional model that we have. So fundamentally, we have to figure out a reimbursement model similar to our professionals, because the truth is, hospitals have never had a problem paying for more doctors or OTs or PTs, but they always, always, always have a problem paying for more nurses. And we can change that. We know that that model can change and we can solve this. So yes, I'm putting together a national commission to take this issue on. We know it's going to be highly challenging. It's going to take us 5 years. But even to this point, everybody's like value-based care. Nurses don't even have a national provider identifier, which means right now, value-based care can't even track the value of nurses into their NPI calculations because they are, again, hidden. They're going to give all the credit to the room for basically delivering this care that drove better outcomes, when in fact, we know more than studies have shown that it is actually the nursing care that drives the best in outcomes.
It drives me insane how invisible nurses have been for so long. So about 15 years ago, I was working with a specialty pharmacy as a client. And I remember, my background is in marketing. So at the time we were their agency of record and we were helping them with marketing. And the sales team was talking about their 4 Ps, right? The patient, the provider, the payer, and the pharma company. And we were specifically trying to help them message and get in front of effectively providers. And they kept saying, Roxy, we need a message to get in front of the doctor. We're going to the doctor's office. This is our territory. This is our sales strategy. And it was all about the doctor. And as I started to dig in, I was like, guys, we have a fundamental problem. You are actually not engaging the doctor. From the conversations that you're telling me, you have no desire to talk to the doctor. You're actually trying to circumvent the doctor because they aren't the decision maker. They aren't the one that's really influencing where the referral is going, where the patient is being directed for their next step of care, for their medication treatment. And you have just really rendered them completely invisible, like on the brochures, on everything. It's doctors, and you're not even wanting to talk to the doctor. We need to change this if we're going to be effective. So
you need to talk to the nurse, right? You're saying they needed to talk to the nurse, right? This is what has happened, because the truth is the doctors do have a payment model, right? They are the center of the care delivery. But to your point, the people who actually make the system function all of the time are the nurses. And I'm just so glad you shared that story, Roxy, because the reality is if we don't start addressing this differently, if we don't start recognizing the value of nursing, I only can imagine what that means. I cannot imagine a world without nurses, and what it means to society, and who is going to care for you when nobody else will cross that threshold. And we know that during COVID, for example, everybody else ran for the doors. There were no doctors in hospitals during COVID. It was all nurses. Yeah. And the reality is that people don't talk about that. They don't talk about it was the nurses who stayed by the bedside every single day when there was no treatment. They risked their lives. There were more nurses who died from COVID-related infections than by about like 50% more than any other colleague on the front lines. And it's okay
before putting the patients' lives before their own.
They did constantly. And do you know what's happened since COVID's end? They've rolled back all the advancements that nurses made during that time. When all the administrators worked from home, all the doctors worked from home, nurses took over back to running those hospitals, right? They did everything. They elevated their profession. They set up all the field hospitals. They managed all the supply chains. They took down all the areas of healthcare that were broken because everything that we knew in COVID failed us. So we had to reinvent it. And then COVID's over, and they're rolling these nurses and these advancements back, making them invisible again in this process. And I can't blame why my colleagues are leaving in such force. The average age of a nurse in this country is 52. 40% is over the age of 40. But even what's scarier is we graduate 175,000 nursing students a year. Mm-hmm. Prior to COVID, 50% of that population would leave the bedside in 2 years of practice. But we believe that this year, 70% of those new grads have left the practice of nursing, the bedside, which means to me is that we'll produce tons and plenty of nurses. We actually have more nurses today in history than ever before in the history of the United States. We have a shortage of nurses willing to work in healthcare environments as they are staffed, as they are paid, and as they are valued today. We don't really have a shortage of nurses. We have a shortage of nurses willing to be treated the way they are in healthcare, as these commodities, as they are dispensable and disposable and unvaluable and unseen. And until we rectify that, and in all honesty, I have racked my brain for 20 years to figure it out. It all came down to this one simple thing, which is as long as nurses remain a cost center to healthcare institutions, we will never solve this problem.
So tell us a little bit more about this reimbursement model that you're talking about for nurses. This commission, who are the enforcers or change makers that you're going to be engaging, and what can our community do to help support that transformation?
Oh, thank you for asking. So, Roxy, just to let you know, this is not far from possible. In fact, actually, when DRG codes were first established in the 1980s, they had an entire section based on nursing reimbursement codes. They were all built there, but there was heavy lobbying to have those removed, right? They were heavily removed, but they all are there. In fact, Germany actually just redesigned and put DRG codes back in for nursing so they could create a sustainable nursing workforce. So it's not anything that we can't do. And the truth is, who's going to be on this commission? Chief Nurse Executive of Emory Healthcare System, Sharon Pappas. John Welton, one of the foremost nursing historians in the country on this issue of this dealing with Medicare, is also being on this. We have approached Betty Rambler, who's the only nurse on MedPAC, who recognizes, I had a great phone call with her, recognizes that if we don't change the financial model, we won't change the behavior, and we must change the financial model. Rhonda Anderson, who was the president of the American ANCC, American Nurse Credentialing Center. And then we have Marion Leary, the first nurse ever to be the head of innovation at University of Pennsylvania. We have Matt McHugh, one of the foremost nursing researchers, and we're in discussions with several others to put out and round out at 12 for a total. And then we're putting together committees and going forward with basically saying, look, we at minimum need a national provider identifier. This is very easy to do now based on electronic EHRs, very easy to manage and track, help support value-based care. And in the interim of that transition, here is the actual model that we can take from Germany, the exact model that we can take as proposed in the 1980s for a DRG model. But if there is anybody that's listening that wants to help, I think the truth is that there has to become a fundamental understanding that we cannot invest in costs. Nobody will ever do that. So they need to come to Congress. They need to say, healthcare companies need to say whose sales are down because they're saying all the hospitals are saying, look, we can't afford your product because we're focused on the front line. We have to form a coalition together of businesses to say we need to change the financial model around nursing. Nursing is not only important to healthcare systems, they are fundamental to our society. And we as a country are going to come together to find a way to stabilize this profession. It's not just investing in more education. That's not the problem. As I said, we produce funding. It's about creating a reimbursement model that elevates that profession, makes them no longer invisible to the healthcare ledger, and keeps them equal to all of their other healthcare professionals out there who can manage and charge for their services. And hospitals won't have to go bankrupt trying to maintain that population because there'll be plenty of funding to do that and add that value for their reimbursement purposes.
And it's so fundamental to life, to our families, to our communities, to society. I always talk about how, when we're talking about innovation in healthcare, it's so different when you're talking about other industries. It's like, who cares if we don't have the iPhone 16, right? But this is fundamental. And so what we're doing with nurses is that, it's really personal if we go to the hospital with our family or ourselves and there's no one there to take care of our loved ones. Like that's an issue. And we don't want to wait till we're experiencing that firsthand before we start making changes.
And you know what the truth is we are seeing it firsthand, right? So we know that hospital emergency room times are going up to 19 hours, 20 hours. By the time you're actually getting into a hospital room, it's 72 hours. And infections, and by that time, 72 hours of no treatment in an acute environment that's the difference between life and death. We know nurses in Washington State are calling 911 because they are so short-staffed that they're asking for the fire department to come in and manage these situations. And the reality is what we're realizing is hospitals are already shutting wards and floors because they don't have the staff to be able to deliver care. And in an interesting case, what happened in North Carolina, Novant's healthcare system, the treasurer of the state of North Carolina actually pulled their state Medicare and Medicaid funding because the hospital had stopped paying for nursing staff, saying it was too expensive. Wait times were going up to 20 hours. Patients were actually dying in the emergency room. And the state treasurer literally says this in an article, saying that it is hospitals, cartels, operating as nonprofits that are destroying the system. So when they suspended payments to the hospital system, suddenly the hospital system had all of the money in the world to hire back this nursing staff to make sure that they have a commitment to keeping these emergency rooms open and operating. And I think the truth is fundamentally, if you and your community are showing up in emergency rooms and you're waiting 20 hours and they're saying it's a nursing shortage, we need to be talking to our treasurer's offices to say, where is this money going? Who is getting paid what? And where are the resources going? Because the truth is without having nursing staff, you cannot keep floors open. You cannot get patients through, and people are going to die that we love. And that is the most upsetting part of this.
Mm-hmm. Absolutely. Or even us, right?
Yeah.
So it's so personal. So there's another solution that I've seen you talk about before with national licensure for nurses. Talk about that a little bit and what that might mean for our ecosystem.
So right now, to be able to practice as a nurse, we all sit for something called the NCLEX. It's a universal exam that nurses sit to. In fact, nursing education is standardized across the country. If you go to nursing school in Massachusetts, it's the same as going to nursing school in Kansas, Kentucky, Florida, wherever. The NCLEX, you pass. It is a national licensure exam. It means you're qualified to work in any state. What does not happen, though, is that nurses only can have a state-issued license, which means a nurse in Massachusetts cannot work in Maine, even though they are qualified to do for, except if they get another license. So what would help is if we basically say, you become a nurse, you don't need to host and own a license in all 50 states. In fact, there's something called the Compact Licensure Program, which does allow nurses within about 16 states to easily flow into it, because it's also very costly to obtain these licenses and keep them up to date. So if we lifted that and allowed for a national nurse license across all 50 states, the reality is the workforce could move where it was needed in the most acute events. I remember at the beginning of COVID, a hospital in Washington said, if you want to do something to save this healthcare system, to allow us to survive, you need to lift the restrictions on nursing licensure so they can practice across state lines and easily move across the country. So not only a license restriction allows you to practice, but also a credentialing passport. This is also a barrier to it. Credentialing can take up to 90 days, 6 months for nurses to get credentialed with a hospital. But the policies of credentialing are largely equivalent across all acute care, all post-acute. You create a credentialing passport that nurses could take with them to easily maneuver into healthcare systems, and you virtually would optimize this workforce in ways that we currently do not allow to happen.
So we just created a bunch of barriers that just make it more difficult for us.
Yes. Exactly.
Is that part of your commission as well? Kind of bundling all of these issues together and trying to overcome those obstacles?
So in my day job, we take on the issue of credentialing, passporting. We do this for our workforce. We have about a 50,000 nursing workforce that works across long-term care, and within their states, they have one license with us, one ability to practice, and can work at multiple facilities with us. Yep. For the commission, no. I think the truth is that to be effective, we have to be singularly focused on one issue. As soon as you conflate the issues, more opportunity comes to tear this down. And we know we're going to lead large resistance to this. I don't know why anybody wouldn't want to quantify or value nursing or reimburse that so that you could actually track the dollars that are going into healthcare in a meaningful way to know where they are. But we know that as soon as you bring in money, that means that others will feel threatened, that their dollars potentially are at risk. So we believe, or what we think, is that we have to stay centrally focused on this issue, because once we resolve the issue of reimbursement and creating a sustainable economic financial model for nursing, we can then go and talk about those other things to deal with those other lessons. Because in that sense, some of those issues would be great, but you're still putting a Band-Aid on a bleeding system. And the truth is we're not going to address it until we figure out the finances.
So cheers to you and your team and all the work that you guys are doing to dismantle the status quo around nursing. It's really, really incredible work. So thank you for that. And thank you for joining me today. Is there anything else that you would want to share with our audience before we wrap up?
Well, Roxy, I just want to say, I think if there is one thing, it would be if you do not have a nurse with a seat at your table, and you're in a crowded room and you see all these decision makers, you need to make sure that there is a nurse there. And not only that she or he is there, but they are given the chance to engage and converse and impact the outcomes of the problems and the solutions that you are looking to solve. And if we all did that, we could change and perhaps sustain and scale this profession, who every day is facing the largest exodus of any profession that it feels like only a few of us are actually talking about. So just thank you for having me and sharing your own story and showing that value, because if it wasn't for conversations like these, somebody like you inviting me as a nurse onto your incredible platform and the reach that you have, none of this would change. And I can't tell you how much of an honor it is to be here and to be able to represent what's going on in nursing. So thank you for having me.
Oh, thank you. So how can folks get a hold of you after the show if they want to learn more about the commission and the work that you're doing?
Yeah. So the best way to reach out to me, honestly, is LinkedIn. I know that's crazy. It's just Rebecca Love at LinkedIn. You can find me. There is a porn star with the same name. So just put in nursing along those lines. I'm not her.
I'm so glad you gave us that disclaimer.
I Googled you and I'm like, not that Rebecca, not that Rebecca Love, another one. So, but LinkedIn is perhaps the best way. I pay very close attention to it. If they want to email me, they can of course find me at IntelliCare, rlove@intellicare.com. But the truth is that please engage with me on LinkedIn. If there's, would love to amplify any of the voices that are out there, because I think there's so much that we could do to share and change the conversations going on in healthcare.
Awesome. Thank you so much. Thank you so much for listening. I know you're busy working to bring your life-changing innovation to market, and I value your time and attention. To get the latest episodes on your mobile device automatically, subscribe to the show on your favorite podcast app like Apple Podcasts, Spotify, and Stitcher. Thank you for listening, and I appreciate everyone who shared the show with friends and colleagues. See you on the next episode of Health Innovators.